My name is Ali. I'm regional advisor for health system resilience in WHO EMRO. I'm leading a team that is responsible for interdisciplinary areas such as the health system resilience itself, health system recovery in emergencies, humanitarian development, peace nexus, and refugees and migrant health. And the region actually, I wonder if you are aware that WHO EMRO is covering 22 countries, starting from Afghanistan and Pakistan at east to Morocco at west. And we cover nine actually African countries as well, majority the North African country, but it goes down to the actually Sudan and Somalia as well, Djibouti included. And the whole idea around the work that we are doing is trying to make our support to the countries in the middle of crisis or post-crisis more systematic and predictable. The point is that the recovery process in FCS is, the confusing and dynamic by itself, and so as such, we need to act and basically work in more harmonized way and more predictable way in terms of the coordination, finance, technical cooperation, etc., etc. And as such, we proposed for the first time in WHO, I would say in 6 regions, a technical paper on the health system recovery in FCS that will be presented throughout after like a long consultations with the experts and member states in the regional committee that will be held in coming October. And the importance of this work is that it has a resolution attached, and resolution is a kind of it has asks from the member states and some commitments for the secretariat that is the WHO. So, and hopefully, if the member states endorse the resolution, it will give a huge power to us to follow up with our recovery agenda in a more systematic way. So, in our region that I mentioned, the 22 countries, we have 9 FCS according to the World Bank. Including Afghanistan, Sudan, Somalia, Syria, Palestine, actually Yemen, Iraq, Libya, etc. And then again, according to the definition, so the FCS is marked by protracted conflicts intertwined with the weak institutional and governance capacity that limit the ability of that country to maintain peace, deliver essential services, and foster development. And it is almost true in all the countries I mentioned. Another aspect that is very challenging is on top of that protracted emergencies, weak governance and institutional capacities, there are overlap of the emergencies, natural and man-made. Example includes the explosion of the Beirut port or the large destructive earthquake in Syria, among many other examples. Nowadays, right now, we have about 115 million people in the region in need of humanitarian assistance, and over 31 million people forcibly displaced. In this slide, actually summarize how this fragility, conflict affected the situation, affected the health. And you see a clear higher maternal mortality rate, neonatal mortality rate, under 5 mortality rate, lower life expectancy at birth, lower service coverage, actually lower financial protection, as well as lower emergency preparedness capacities. By definition, and I would say here that that was for the first time that in the WHO in EMRO region we developed a guide for implementation of the health system recovery in emergencies, and it was 2019. And following this work that we are working on the RC paper, we are actually revising that. And that guide in 2019 was the basis of whatever we try to work with the countries during last few years. And according to the definition introduced there, recovery is actually is a process to reestablish disrupted health services, restore health system building blocks, and reinforce essential public health functions, with the aim to accelerate progress toward health-related SDGs, mitigate future risk, and contribute to the national development. And for sure, it's a prerequisite for the and mean to promote social cohesion and peace building in that country. It's not easy process. We always should expect unexpected. We have example, for instance, in Afghanistan, after decades of instability, became stable somehow for a few years, and that was in 2000, actually 21, that again, Taliban regime came back and the country came back to the pure humanitarian situation. Sudan is another example that was trying to recover and develop somehow. It was a pioneer in implementation of the Nexus approach. And then again, we have the escalation of the hostilities. And now we have, it's actually the worst humanitarian crisis we have in the world in terms of the number of displaced. And the characteristics that make it not straightforward and not simple and easy are they are prolonged usually, and as I mentioned in the examples, the transition is usually non-linear. Fragility, the peace and security situation is fragile, the governance is disrupted, and with inadequate capacity. We have examples of actually, for instance, Yemen, we have north and south. We have example of Afghanistan that we actually work with de facto authority at the technical level. We have east and west of Syria with different capacities and legitimacy. Syria before, at the time of the Bashar, we had 3 response areas with different situation and governance. The funds is unpredictable. It's come mainly from the humanitarian side. The development side is very much related to the Security Council peace-related resolutions and on the all big political discussions. Shortage of expert workforce in Syria. Just according to one of the study, 50% of the medical personnel left the country. And humanitarian development divide. The systems that actually follow their own different systems, way of working, guiding principles, etc., etc. Oh, in the middle of this situation, we also try to be positive and think about the build back better approach if doable. When it comes to the pure natural disasters like post-earthquake, post-flood, it's more understandable. However, always there are some maybe opportunities to fix some of the previous weakness of the health systems of conflict affected. I will provide a few examples later. But the entry points are addressing neglected areas such as mental health and NCDs, building damaged facilities to be disaster proof, health service provision with revising the essential package of the health services, make it more comprehensive or fit to the new needs of the population, policy reform for the governance subjects, for the finance and disaster risk management. In WHO EMRO, the regional director has initiated three flagships focusing on the health workforce, access to medical products, and substance abuse. And those actually can be leveraged for the Build Back Better opportunities in recovery process in FCS. No need to mention, if we want to have an effective recovery, it should be well planned, well implemented, and supported by strong will and adequate technical and operational capacities. You know, there are globally known methodologies and mechanisms, mainly under a tripartite collaboration between EU, UN, and the World Bank, known as post-disaster needs assessment, and its extension depends on the situation, can be a rapid disaster and needs assessment, etc., etc. So those basically provide us with a collaboration and coordination platform led by the government, supported by the EU, UN, and the World Bank. It has a methodology for the assessment of the needs, the impacts and needs of the recovery. And the result will not end to the assessment report. It follow with development of disaster recovery framework, the donor conference, and the fundraising situation. And also another mechanism that is recovery and peace building assessment, RPBA. In new version of the recovery implementation guide, I try to visualize whatever is needed to be in the operational framework of the health system recovery in FCS. This is the situation as you see, and basically the recovery phases are early recovery and transition, long-term recovery. And the early recovery actually starts while we are responding to the emergency needs. It's a dynamic process. It has a progress and the regress of the peace and security situation. It has 6 steps that are not necessarily being done in a clear sequence. Starts with the recovery assessment, followed by development of the framework, strategy and plan, resource mobilization, implementation, monitoring, and evaluation. And before all of that, recovery readiness. That we learned basically, it's super important that be ready in terms of the needed coordination, needed data, actually technical support in place to able to conduct these steps. And these steps for sure can happen in an FCS several times. And the whole idea is the same. Whenever we want to start any recovery attempt, is these steps can be done. And what we are going to recover, as I mentioned once in the before in the definition, they are the famous health system building blocks and essential public health functions. However, in the case of the FCS, what is important, we have different group of the actors. humanitarian development as well as those interested in peace action. And bringing these together requires a methodology and approach that is called as humanitarian development peace nexus approach that ideally, for the long-term recovery, it should be aligned with the national health strategy with the aim of achieving health-related sustainable development goal. And one of the important thing in this framework is that the recovery readiness that I put here actually twice, when at the time of the emergency, as part of the emergency preparedness effort, whenever possible, and the second time, whenever during the emergency and the protracted conflict, we want to have a recovery attempt. And some examples from the initiatives that the countries have taken toward the health system recovery. And however, whatever I mentioned in the framework is understandable that cannot be done at the same time in a same shape everywhere. This depends on the context. But these are examples that can be further reviewed and learned for similar situations. One of the things that we did almost immediately after 7 October in Gaza was establishing in WHO a three-level recovery working group. Deploying technical staff to the country office, actually looking at all the coordination mechanism and data needed, and the result was significantly contribute to the all the recovery assessment and the planning that have been done so far in Gaza by the World Bank, by the actually Palestinian Authority, etc., and the partners. This is an example from an early recovery attempt in Sudan, despite the very difficult situations they have. They tried to actually use the existing maternal death surveillance and the response mechanisms they had. They applied some adaptive strategies, and as the result, you see in 2024, 1,024 maternal deaths were reported, that 84% of them underwent a comprehensive review. And actually, those review resulted in targeted interventions in emergency obstetric care, IPC, and training and supervision of the health workers. The message here is that despite that situation, some attempts can be done to recover some parts and some functions of the system based on the existing or previous capacities. This is an example of the overlapping emergency in Syria, a post-earthquake recovery while responding to conflicts. After more than a decade of the conflicts, Syria faced with this earthquake, and actually post-disaster needs assessment, including health sector, was implemented. And it led to medium to long-term priorities, including rebuilding health facilities, rehabilitating health workforce, enhancing preparedness, and private sector engagement. And however, as expected, funding and implementation efforts face challenges due to donor restriction, especially in the case of Syria, and shifting political dynamics. Another example from Somalia, applying the humanitarian development peace nexus by aligning the humanitarian response plan objectives with the objectives of the health sector strategic plan, with the focus on PHC approach and expansion of the essential package of health services, as well as establishment of the Somalia Joint Fund, inclusive of partners and donors. And the last example here is that Iraq, that has a different situation in the region, is now is called a post-conflict. Of course, like Libya, it's the cluster system is deactivated, and the country has its own actually oil revenue. And now they are working on the actually transition from humanitarian to development. Next week, I will be in Iraq to work with the colleagues on this subject, and they want to take the actually the health insurance law as the operational entry point for the recovery and development of the system. And an example from Build Back Better approach is that the digital transformation of health information system that Iraq is doing right now very nicely. And other examples such as applying public-private partnership policy in modernization of hospitals. I would say I know at least 12 hospitals in Iraq, among others. And it's not easy. It's not the one person, one organization actually job. Needs the support of the all of us, everybody from different sectors and organization, supported by academia for sure, supported by civil society, and with the focus on enhancing the involving the local communities, local resources, and enhancing their capacities that uh, will help with the sustainability of all the recovery efforts. Thank you so much. Over to you.